Good morning, Mr. Dash. Thank you
Hi.
very much for taking some time to see me. We spoke a couple of weeks ago at the Congress about this JUICE 2 that you'd listened to in the lecture, and you saw us on the stand, and now I'm here at your invitation. So tell me a little bit more. What was really interesting for you about that JUICE 2 meeting?
Well, I know that the clinic itself gets some refractive surprises. We get some surgery where, outcomes are surprising, and those patients take up a lot of time. So for me, it's the surgical impact. Also for contact lenses, I know that dry eye is something that I need to look at to improve the wearability of some of these contact lenses as well. So.
Okay. Tell me a little bit more about the surgical side. So are you saying that from time to time that there is a surprise that occurs that it really is a surprise? You don't know what's really happened?
We all have some surprises where we've missed something before surgery. They've had laser eye surgery and they've not told us about it. So I'm not talking about those which we can expect, but it's those where it's a patient that's not had any preconditions and they come in and they end up with some astigmatism, they're overcorrected or something like this. And, I've been hearing at conferences that dry eye might be a cause of that. So, this is just trying to improve my patients' outcomes.
Okay, so that we're critically talking about how we can make a difference to these outcomes in particular. Yeah. Okay.
Also, I get some dry eye patients as well. Patients come in with dry, gritty eyes, and
okay, all right.
My nurse has done things to solve that, but they keep coming back.
But they keep coming back. Well, and this is the problem with the contact lens patient. It's the problem with some surgical patients or just the general public. So I want to just dig in a little bit more, if I may, about something you just said there. What are the kind of tests that you have to look at the tear film today? What do you image before you go to surgery?
Well, we use a slit lamp, obviously. We use some dyes. We use fluorescein. We put them on an IOL master, and so really that's what we're doing before surgery. Okay. We do have a topographer in practice as well. So we use that for some of the K readings sometimes, especially if we're suspicious of dry eye, but yeah.
And when you say suspicious, what do you mean? The patient's telling you it hurts?
Yeah.
Okay. And in your opinion, are there any situations where actually you wonder, maybe something's going on, but the patient isn't talking about symptoms?
Yeah, patients sometimes under-report conditions, we know that. And actually, we're busy. So sometimes we perhaps don't ask the relevant questions as well. So within the clinic, a busy, successful clinic is a busy clinic. So we don't always have the time to really put another level of sort of time within that preoperative surgical.
One thing is interesting here is that, we've known each other for a little while, and I've always thought of your clinic as well-informed, and also you invest in the latest instruments here. But it sounds a bit like you're saying, well, you've actually got almost too many instruments going on. Is it hard to bring it all together sometimes?
Well, boys and toys, we like kit.
All right.
But one thing we don't have is that much space in the clinic now because we have purchased a lot. But maybe, it's a matter of getting the best for our patients, and that really comes from good diagnostic technology. Right. So that's how we get good outcomes.
Okay, all right. Well, maybe I could just summarize for a second, and then if that's okay with you, I'm going to explain a little bit about the technology that our company has, how it fits with this JUICE 2 report, but most importantly, I think from your perspective, how we can help you improve your patient outcomes. Secondly, also talk a little bit about how we can make your diagnostic time much shorter, okay? If that's okay with you.
Yeah, that's the important thing. I don't want another 20 minutes with a patient for dry eye.
Exactly. Okay, so what I'd like to introduce you to is to the new IDRA product from SBM Sistemi. Okay. You talk first of all about managing these patients, some may be symptomatic, some may not. So in the Due2 program, what they've said in their protocol is, first of all, to detect symptoms. So we can do this with a simple questionnaire. It can be OSDI, it could be DEQ5 or SPEED. And what we can do is introduce a very simple questionnaire that can be done outside, in reception whilst the patient is waiting.
But some of my patients are really old and they don't like filling forms out. They don't want to fill out the 3 pages of the OSDI, which I know.
I think one of the beauties of SPEED or DEQ5 is it's 5 questions.
Okay.
And we can always help with this by even helping the receptionist with the patients do it. The beauty of this is you have an indication of symptoms first, okay? And you can kind of put a stake in the sand, just gives you a clue as if something is going on. I think you already have some osmolarity measurements. So the next stage is to try and bring this together. If you suspect dry eye, or if the patient is giving you some information about dry eye, the next step is to try and categorize this. So rather than using multiple instruments, what the IDRA does is bring everything together in simple steps. Now, the beauty of this is that this is not something you need to do.
Okay, I like that.
Okay, all right. This can be either your optometrist, can be even one of your technicians and nurses, and we can come in and train them. There is a simple wizard that takes them through each steps. And this, after some training and a little bit of time, I would expect within a month they will be able to do this test probably in no more than 4 or 5 minutes. Would that be beneficial to you? Absolutely.
I think I saw it at the conference.
That's
you had
right.
this
That's right.
This screen that looked at multiple tests. So,
absolutely it.
okay.
So what we would be able to do then is provide you information, first of all, about the actual tear film itself. We look at the stability of the tear film, the quality. And we would do this using non-invasive tear breakup time, which is done in a 30-second movie. Okay. Once we've got that, we can also look at the meniscus height. So it gives us a little bit of a clue if we have some key evaporative, but also whether there's any aqueous problem there. Once we've got that information, we will probably then go on to looking at actually imaging the myobone glands using infrared. Okay. And again, this takes around about 20 or 30 seconds. It's a short video. Once we've got that information, we put that all together into one suite. And then we'll be able to put that electronically. You can pick that up. And the nice thing here is that as you are looking at the biometry you're doing, so you use a LensStar or IOL Master?
We now go on to the LensStar.
So when you look at the LensStar, you will be able to see on K1 and K2 what is the standard deviation. Yeah. If you see some standard deviation in the astigmatism, you can then have a look at your information and say, right, okay, so I can see we've got a very rapid tear breakup time, so the quality of the tear film. Maybe you've got an osmolarity number that shows some instability between the 2 eyes. So you can make a decision. Is the information I have in front of me stable enough on which to decide a lens choice, or do I want to try and stabilize the tear film before I go ahead? Now, in the case of a toric patient, you might decide that a toric or even multifocal, you need to know the axis is stable and you need to know what the cylinder is stable. So in this case, you'll be able to make an intervention prior, which could save you a lot of time and improve the outcomes. And by the way, I think there's a nice little touch here because it should give you the confidence to increase the number of toric patients you're able to do surgery on without having any
that's
worries.
What a colleague of mine said. He's far more confident. So he's doing a lot of the multifocal and torics. And so that's one of the reasons for asking you in. So,
Perfect. So you would have that information. You can then make a decision as to what you want to do. You can treat over a maybe 2-3 week period. You can use the new IPL, I know that you've purchased, or I think you still have the original J&J LipiFlow system, I think. So, but you will have the ability to choose. So once you stabilize the tear film, you'd be able to see quickly a change on the non-invasive tear breakup time on the IDRA, and you'd probably see a stabilization of tear film on lens star. You can go ahead and make the surgery. Now, there's another little spin-off here that might be of interest to you. Once you've done that, of course, we want the patient to have stable vision post-op. So the nice thing is with the IDRA, you can use this to track what's happening with the patients. So in future, if the dry eye starts to come back, even if it's not particularly problematic to the patient, but in a 5-minute check in 1 year's time, bring the patient back, check here, then you might be able to actually start to develop a new revenue stream for your dry eye patients. And again, the nice thing is this will be done by your technician, your optometrist, and you as the physician simply will decide what the therapy treatments are, and you can track it. Would that be something that would really help you?
Yeah, but actually you're saying delegating some of this. So would you come in and train
Absolutely.
Rosemary or one of the staff really to...
Absolutely, absolutely.
Okay.
And I, you know...
Because in some ways I would almost like this to be a nurse-led or a non... You know, I don't have the time. Okay, I don't have the time to do this, but I do have other members of staff that I pay that...
So in a way, what I would see is that you come in at a certain point where you have this information provided. You use your knowledge and experience to make a decision on what goes and what doesn't, whether to do surgery, whether to delay, and then your nurse will follow these patients in the future. And even with something like the IPL, they could even do the treatments. You don't need to be involved. So if we maybe summarize that, what we could do is give you one single instrument that takes about 3 or 4 minutes. We can do a multiple
But does
battery
this
of
need to be
tests.
done in my consulting room? Because
Absolutely not. This can be done outside. In fact, what I would probably do is do it maybe in a biometry room where you have the IOL master, okay? And we can have a look outside, and let's involve Rosemary and the practice manager and see how we could set that up, because the nice thing is that we can apply this technology also to contact lens discomfort or even to new contact lens wearers. And don't forget, you know, one of the things that Jews identified was that this is a disease not just for our cataract wearers, but this is a disease that we're seeing more and more with tablets and phones, where the patients are getting meibomian dropout in a very early age. And so if we're going to fit them with contact lenses, the same issues are going to occur. So avoid the problem of patient dropout initially by identifying the tear film, making sure everything is healthy. And then in future, before you start making any changes to contact lens parameters, if the patient has a problem, let's ensure the health of the eye and the tear film is stable. And you can do that in 3 or 4 minutes. And that, again, is done by Rosemary. Your job simply is to interpret, validate the information, and make a decision.
have you got time to speak to Rosemary today?
Absolutely. Let's do it straight away. That would be fantastic. All right, so we'll bring the instrument in. In fact, actually, I've brought one with me. And we can set it up. We'll do a little tutorial now, and then if it's okay with you, we'd start probably the week after next.
Okay, sounds
All right,
good.
thank you very much.